General treatment plans for pelvic health include instruction in pelvic floor contraction and relaxation, diaphragmatic breathing, posture training, the surface EMG training for discoordination, so that's the biofeedback training, and treatment of associated musculoskeletal impairments, so lumbar impairments, hip mobilization, pelvic muscle energy, myofascial release, scar tissue mobilization. So all the things we normally do in PT, plus a few extra things. So for incontinence specifically, the PT and PT are going to work on behavior modification. Having people keep a voiding journal, like I was talking about, where you write down what you eat and what you drink and when you void your bladder to figure out what is irritating or what is stimulating to the bladder and try to get people in a normal schedule so they don't feel like they have so many issues with their voiding. So bladder training can help avoid the just in case, like people say, oh, I better go just in case, even if they don't have to go. And using the Valsalva or holding their breath during voiding. So you're really trying to train them into a more natural voiding schedule. Patient education include dietary irritants, and we'll look at a list of those. Bowel and bladder norms, like what's normal and what's not normal. We don't know, right? Or they don't know. So we're going to help train them with that. How often is normal? And drinking water to avoid dark urine. So a lot of people with incontinence will avoid drinking water because they don't want to have an accident, you know. So when your urine is dark, it means it's concentrated. It means you're dehydrated. And so we want to make sure people are getting the normal amount of intake and normal output. Neuromuscular training can be involved in treatment for incontinence and biofeedback training. So foods that can irritate the bladder include acidic foods, like my favorite, coffee. I don't know if that's a food. It has its own separate entry on the list. Alcohol, tomato-based foods, vinegar, which is acidic, coffee and tea, regular and decaf. All those can be irritants. Darn, right? Curry, spicy foods. Substitutions for the acidic foods can be low acid fruits like pears, apricots, papayas, watermelon, coffee substitutes. That breaks my heart to even say that, but there you go. And non-citrus herbal teas can be a substitute for regular and decaf tea if those are irritating your bladder. So the neuromuscular training for pelvic floor, we're trying to establish the ability to perform a functional pelvic floor contraction. So an isometric contraction without substitution by the gluteal muscles, the abdominals, or the adductors. A lot of people, if they can't contract their pelvic floor, they'll contract their glutes, and it doesn't work the same way. The person should be able to demonstrate appropriate timing, intensity, and duration of isometric contractions. And also we can train people who have stress incontinence to do anticipatory control, contracting prior to a cough, sneeze, or a sit to stand. So when you go to people that experience stress incontinence, we teach them when they go to stand up, contract their pelvic floor, stand up, and hopefully don't have that incident of stress incontinence. So a lot of times we're utilizing imagery to assist with initiation of appropriate contraction because you can't really show them, right, how to do it. So sometimes like demonstrating the diaphragm by opening an umbrella or expanding the ribs into tubing or hands. And you use the vision, you don't actually open an umbrella, but you use that visual idea of opening an umbrella or having them put the tubing around their ribs and expand their ribs into their hands. We did that in the pulmonary lab to work on training inhalation. We're doing the same thing, training the diaphragm. With the pelvic floor, people respond to different cues, and I'll tell you some cues that have worked for me. These are some cues that different pelvic floor therapists have told us were helpful. So for women, you can say squeeze or close and lift the vagina. Draw in. You can say try not to pass gas. Pinch, elevate, gather sometimes is a good cue, gather the muscle together. Sometimes I'll tell people that have them sit on a foam roll and lift up from the foam roll. It gives them that kind of tactile cue. That one I have found to be really successful. For men, sometimes say if you're like you're walking into cold water step by step and you're trying to lift up to avoid the cold water, lift the scrotum up and in. Some therapists say nuts to guts for guys, if that works for you. To relaxation, to get someone to relax their pelvic floor, soften, let it fall, down and out, melt, drop down, whatever cue works. So when I was working with the 85-year-old post-surgically who had post-surgical incontinence, um, I tried all sorts of different cues that weren't working for him. And then just talking to him during the other parts of it, we were working on other things during the other parts of his treatment. I found out that he was a regular church goer, and I said, so imagine that you're in church and you feel like you have to pass gas, but you don't want to. What muscles did you contract to hold it in? And that worked for him. So that, just talking to him and finding out what his normal life was like, that was the cue that worked for him. So try not to pass gas. That might work for other people. So you have to try different cues until you find the cue that works for your patient. So something we call the knack, which is you kind of learn when to contract your pelvic floor. For stress incontinence, timing a pelvic floor contraction just before the moment of expected leakage, like you feel like you're about to sneeze, contract your pelvic floor, you sneeze and hopefully don't experience stress incontinence, or right before you stand up from a chair. For urge incontinence, sometimes it's just squeezing or gently using pelvic floor contractions to reduce the urge, and sometimes distracting yourself from it. So you say, okay, I'm home. I need to go to the bathroom, but I'm going to contract my pelvic floor. I'm going to go carefully set my stuff down. I'm going to contract my pelvic floor again. I'm going to walk slowly into the bathroom. So kind of putting off that urge so you're not crashing into the house, throwing things down and running into the bathroom. So one time when I was in a ski patroller, I stayed up in the top. It was a snowy night and it was night skiing, and I stayed up in the top shack all night. People brought me food and drink, and there was no bathroom up there. So by the time I was ready to go, I really needed to go to the bathroom, and I was streaking down on my skis, and I noticed that the lift operators had left their enclosure up, and so we had to take it down to make sure it didn't get run over by the groomers. And so I had to stop, get off my skis in deep and falling snow, take down the enclosure. So by the time I got back to the lodge, I really had to go, and I did throw my equipment down and run into the bathroom. So but you can use that distraction or gentle pelvic floor contractions to diminish the urge a little bit so you don't have to run into the bathroom. So, for special populations for pelvic floor dysfunction, pregnancy and postpartum is generally an area where pelvic health issues come up, which is a lot of times why it's considered women's health. But you're going to modify exercises by trimester. Obviously, you can do more in certain trimesters than others. The therapist is going to do diastasis recti assessment and treatment, pelvic girdle pain management, and preparation for labor and delivery. Postpartum, we're going to help patients with a timeline for return to exercise, the C-section precautions if they had a C-section, and scar management. Breastfeeding considerations, they might be seeing a lactation consultant. They might need referral to a lactation consultant, and return to sport and activity protocols. So the things that you really want to look out for postpartum are severe abdominal separation, heavy bleeding or unusual discharge, severe pain or pressure, or signs of infection. So those are definitely send back to the doctor signs, those red flags. So during pregnancy, most women gain between 25 and 35 pounds, and the uterus increases in size 5 to 6 times its original size. That's amazing, right? The uterus, instead of being a pelvic organ like it normally is, it becomes an abdominal organ because it increases in size so much that it moves up. The ureters change the angle to enter the bladder more perpendicularly because they're getting pushed aside by the uterus. The lower rib cage flares up and out. And I have had people tell me that after their first pregnancy, they wore a different size, not because they gained a bunch of weight, but their rib cage actually changed. And so certain things didn't fit them anymore. So I thought that was kind of interesting. The diaphragm elevates because it has to get out of the way, right? And the center of gravity moves anterior and superior. So it changes your posture. And the interesting thing is during the whole process, it's changing every day. So your balance is changing every day. Your center of gravity is moving, it's changing every day. And all these changes are happening all the time. So it's kind of an interesting thing. I personally have never experienced it. Some of you probably have. But as when you're treating someone in therapy who's pregnant, it's interesting to see the changes that they're going through. So physiologically, oxygen consumption increases, blood volume increases, blood vessels relax, and that can create orthostatic hypotension and dizziness with change of position. Venous pressure increases, and that can create venous stasis and varicosity. So a lot of people get varicose veins when they're pregnant because of that pressure increase. There's increased extensibility of connective tissue because of the pregnancy hormones. Um, so in the first trimester, blood pressure decreases, and then it rises in the third trimester because of that increased blood volume and increased demand. Cardiac output increases by 30-60%, heart size increases, and the heart elevates. The lower sweat point assists in thermal regulation because you have this person growing inside of you, and it makes you hot, and so you sweat faster. Interesting, right? Sweat at a lower temperature. Musculoskeletally, the abdominal muscles lengthen and stretch, especially the rectus abdominis. So diastasis recti, where the abdominal muscle, the rectus abdominis muscles separate, it's the ligamentous tissue that separates in between them. The pelvic floor drops up to 2.5 inches. Reduced tensile strength of ligaments results in hypermobility, and spinal curves are increased, partially because of that hypermobility, partially because of the shift in center of gravity. So in pregnancy, 5 days a week at moderate to hard level reduces fat gain in pregnancy. Most pregnant women that I've talked to say it also makes them feel better, and that's always good. The fetal benefits, the fetus benefits from exercise just as much as you do. One time I was in a yoga class, and it was a class where we did chanting, and there was a lady in there who was pregnant, and she said the baby always really liked it when we chanted. She could like feel it sort of relaxing. I just think that's so cool. Exercise increases cardiac output and improves blood flow to the fetus, and that can only be good, right? So if somebody has heart disease, lung disease, incompetent cervix, um, a risk of premature labor, persistent bleeding, placenta previa after 26 weeks. It's where the placenta dislodges from the uterine wall. Preterm labor, ruptured membranes, severe anemia, preeclampsia, or pregnancy-induced hypertension. All of those things are contraindications to exercise per the American College of Obstetricians and Gynecologists. So we don't want to make people exercise if any of that stuff is going on. We should use caution with higher impact activities, although people can exercise pretty intensely all through their pregnancy. You need to use caution if you're doing any activities that have a risk for falls or injury, because the center of gravity is always changing, balance is changing, so some activities may be more risky. Stick to familiar activities, things that the moms used to doing. 5 times a week, 20 to 45 minutes a day, a rate of perceived exertion of 3 to 4 out of 10. So normally we go to like 7 to 8 out of 10, so a little bit lower exertion. They should be able to talk through the exercise, and the exercise should be fun. It should be enjoyable. So if it's not enjoyable, maybe we can help them find an exercise that is. Strength training can be helpful for improving fitness. For postpartum tasks, you got to lift that baby with your arms after it comes out, right? So being stronger. Functional training is useful for lifting, carrying, and body mechanics. Pelvic floor and abdominal exercise is highly beneficial, working on both contraction and relaxation. You want to avoid Valsalva because it has an impact on the pelvic floor as well as on the thoracic cavity. You want to avoid supine positions because it puts the baby can put pressure on the aorta. So you can use wedges or balls. Seated, standing aquatic therapy is wonderful for pregnancy. Avoiding pressure on, and if they have diastasis recti, using upper extremity bracing. And we want to avoid overstretching joints because everything's hypermobile at this point. So the things that can be reported in pregnancy: low back pain, rib pain because the rib cage is expanding, diastasis recti, that's where the connective tissue between the two sides of the rectus abdominis gets pulled apart. Spine pain and postural because of postural changes, sacroiliac pain because of weight shift changes, varicose veins because of that increased vein pressure, and nerve compression like thoracic outlet syndrome and carpal tunnel syndrome are common in pregnancy. So to prevent pain and to treat that, education about postural changes, supporting the spine and pelvis in functional activities and during rest, safe and regular exercise, education on body mechanics, relaxation training, the use of a belly band or SI joint support. So that's what this picture is. That can be really helpful for supporting the changes, especially in the third trimester. Compression stockings to help with venous return, avoid those varicose veins, and activity modification. So there are lots of ways we can support people through pregnancy and make some of these things better. Isn't that nice? I have done with manual therapy, I've done trigger point release and a lot of myofascial release and other manual treatments for pregnant women, and they say that it's very, very helpful. So that's nice. I like that.